Good morning, everybody. The topic is 50 years old, clear lens. So there's no mention about any refractive error. So I presume the patient is emmetropic. He is 50 years old. He has a clear lens and he wants spectacle independence. So when a patient comes, these surgeries are not forced surgeries. The patient come, they want spectacle independence, so we have to give them the options. So there's no financial interest. My choice will be a presbyopic IPCL. My reasons are, why to disturb a clear lens? Why to disturb the optical system of the eye, the natural optical system of the eye? And we have got a reversible procedure, which is, the predictability is better. There is a rapid visual recovery. The adaptation is very fast, and we always give the patient a chance for a better option in future. When we do refractive lens extraction, cataract surgery, the most dreaded complication is RD. In younger patients, there is a high risk of PCO and PCR, CME, because these patients generally don't have PVD. The 50-year-old patients, we don't get many patients with PVD. So, and retinal detachment can occur days, weeks, or months after the treatment, and there are feared postoperative complication of RLE. It's postulated that the pseudophakic RD occurs as the reduction in the lens volume draws the anterior hyaloid face forward, with vitreous-based traction resulting in retinal breaks. And in cases of patients without PVD, so the incidence is more. The debate of refractive lens exchange has been there since last couple of decades actually, and still it has not resolved. This was published in 2005. Then we have many reports in 2020 or 2019 in the last 4 or 5 years, which identify young age as a very important risk factor in cases of clear lens extraction, which can lead to RD. There are many studies. The most modest increase is reported by Shiu et al., who in their final follow-up study found a relative risk of 2.69 for patients aged under 50 compared with those aged over 60 years. And the largest age-dependent risk modification is reported by Pitosis et al., who found those aged under 60 had a 40-fold greater risk of pseudophakic RD than those aged over 80. It does not mention 50 years, but we can see how age has a definite bearing on the incidence of RD. Jerem et al. Note that above the age of 50, the risk of RD drops exponentially by just over half by each decade. This was published in November 2024. They identified they have charted the effect of axial length and as well as age. So we can see in the less than 60 years of age, the incidence of RD is 2.4%, and in between 60 to 75, it drops down to almost 1/3, to 0.65%. In younger patients, the risk of PCO is much more, and it is again, it needs YAG capsulotomy, which comes with its own complications in cases of younger patients without those who don't have PVD. Fluorescent flashes, CME, raised IOP, and IOL pitting is another major issue. So do we have any better option? Presbyopic IPCL IOL is the answer. Why? Because it's a reversible procedure. If the patient is unhappy, we can remove it, and we know that how easy it is to remove an IPCL as compared to an implanted IOL in the bag. The available reserve procedure is still left. It gives a clue to choose an IOL when needed. And if we have to change, if we have to go for a cataract surgery later on, we can always choose on the basis of the experience of the patient, whether he was happy with the diffractive or EDOF variety of lens. It has a better visual outcome, and there is hardly any adaptation time. There is the recovery is immediate. The wow factor is there. No neural adaptation time is needed, and it is an adjuvant to the natural lens. We are not disturbing the natural optical system of the eye. And the most important factor is that it gives an opportunity for a better technology. A 50-year-old patient with clear lens we can safely say that around 10 years, more than 10 years opportunity he has got. And we know just now the discussion was there that how fast the things are evolving. We still don't have any perfect trifocal, perfect multifocal lens. So what lenses we are using now, we are not going to use them 5 years, 10 years down the line. So we definitely know that we can give a better option to the patient in future. So if the patient comes to me with a 50-year-old patient comes to me with a clear lens, I would explain him both the options. If the patient chooses one, fine. But if he asks me, what will you do? You decide for me. Then my preference will be a reversible and a less invasive phakic IOL.